All right. Um, let's talk a bit about the innervation of the abdominal wall. So, we've got thoracoabdominal, subcostal nerves, iliohypogastric, ilioinguinal nerves. Tell us a bit, systematize it a bit for us.
The abdominal wall is innervated mainly by the thoracoabdominal nerves, which arise from T7 to T11 and supply the rectus abdominis and obliques, while T12's subcostal nerve innervates the lower abdominal muscles. The iliohypogastric and ilioinguinal nerves from L1 provide sensory innervation to the lower abdomen and motor innervation to the internal oblique and transversus abdominis.
Okay. And what about the arterial supply to the anterior abdominal wall?
The anterior abdominal wall gets its arterial supply mainly from the superior epigastric artery, branching from the internal thoracic artery, and the inferior epigastric artery, from the external iliac artery, which anastomose within the rectus sheath. Additionally, superficial branches like the superficial epigastric and circumflex iliac arteries from the femoral artery supply the skin and subcutaneous tissues.
Why is it called circumflex?
The term circumflex and arteries like the superficial circumflex iliac refers to their curved or arched path as they wrap around structures like the iliac crest to supply the skin and tissues of the abdominal wall. It comes from Latin roots meaning to bend around, describing their looping trajectory.
Okay. And what about the superior epigastric artery and the inferior epigastric artery? The femoral artery, the intercostal artery, the internal thoracic, the musculophrenic, the subclavian.
The superior epigastric artery from the internal thoracic artery, itself from the subclavian, descends to supply the upper rectus abdominis, while the inferior epigastric artery from the external iliac, not femoral, ascends to supply the lower rectus, both anastomosing in the rectus sheath. The musculophrenic artery, also from the internal thoracic, supplies the diaphragm and lower intercostal spaces, while intercostal arteries, from the aorta, mainly supply the intercostal muscles, not primarily the anterior abdominal wall.
Okay. And the superior and inferior epigastric arteries, they enter the rectus sheath. How come?
The superior epigastric artery enters the rectus sheath by descending behind the rectus abdominis muscle, piercing the posterior rectus sheath near the costal margin, while the inferior epigastric artery enters by ascending from the external iliac, passing through the transversalis fascia and posterior sheath below the arcuate line. Both travel within the rectus sheath to supply the rectus abdominis and form an anastomosis, ensuring robust blood flow.
So a rectus sheath hematoma is the rupture in one of those epigastric arteries?
A rectus sheath hematoma is often caused by a rupture or tear in the superior or inferior epigastric arteries, or their branches, within the rectus sheath, typically due to trauma, coughing, or anticoagulant use. Blood then accumulates between the rectus abdominis muscle and the sheath, forming a painful mass.
Okay, and now I want to talk a bit about the inguinal canal then. So this is an oblique passage tunnel that extends downwards and medially through the lower anterior abdominal wall. We have a deep inguinal ring and a superficial inguinal ring. Could you explain that a bit, please? And do the balls go through during birth or something?
The inguinal canal is a short, oblique tunnel in the lower anterior abdominal wall, running downward and medially, with the deep inguinal ring an opening in the transversalis fascia at its lateral end and the superficial inguinal ring a gap in the external oblique aponeurosis at its medial end. In males, the testes descend through the inguinal canal from the abdomen into the scrotum during fetal development, around the 7th month, guided by the gubernaculum, but this process completes before birth.
Tell me more. Sorry, I didn't understand the ball thing, and tell me more about the deep and superficial ring differences. So the deep one, you have an entrance to the canal midway between ascis and pubic tubercle, and then with the superficial, it's like an exit of canal close. I don't understand.
Let me clarify the testicular descent and the inguinal rings. During fetal development, around the 7th month, the testes move from the abdomen through the inguinal canal to the scrotum, pulled by a structure called the gubernaculum, and this happens before birth, so the balls don't move through at birth itself. Now, the deep inguinal ring is the entrance to the canal, located in the transversalis fascia, about halfway between the anterior superior iliac spine, ASES, and the pubic tubercle, where structures like the spermatic cord in males or round ligament in females enter. The superficial inguinal ring is the exit, a triangular opening in the external oblique aponeurosis, just above the pubic tubercle, where these structures leave the canal to reach the scrotum or labia.
Okay. So what is the difference in their function? And during an operation, when we're older, can the balls go out during the operation through the canal?
The deep inguinal ring is just the entry point to the inguinal canal where the spermatic cord or round ligament starts its path, while the superficial inguinal ring is the exit, allowing these structures to reach the scrotum or labia without any active function beyond being an opening. I'm unclear about your operation scenario. Testes don't move through the canal during surgery or after death, but in procedures like hernia repairs, surgeons access the canal to fix weaknesses, and the testes remain in the scrotum unless the surgery involves them, like in an orchiectomy. Can you clarify what you mean by balls go out?
Is there any surgery that will make the testes move through the inguinal canal, perhaps by accident?
No surgery intentionally moves the testes back through the inguinal canal, but in procedures like inguinal hernia repair, surgeons work near the canal and could accidentally displace an undescended testis or retractile testis if it's not properly fixed in the scrotum. This is rare, as the spermatic cord's length and scrotal attachments usually keep the testes in place during such operations.
Wait, dude, I don't understand. So there is a chance accidentally the testis might go from the sac back to the deep ring.
It's extremely unlikely for a testicle to accidentally move from the scrotum back through the deep inguinal ring during surgery, as the spermatic cord is anchored and the scrotum holds the testes in place. In rare cases, like with a retractile testis or during complex hernia repairs, a testicle could be manipulated closer to the canal, but it wouldn't pass through the deep ring without deliberate surgical intervention.
Okay, let's talk about the borders of the inguinal canal.
The inguinal canal's borders are defined by 4 walls. The anterior wall is formed by the external oblique aponeurosis with some internal oblique laterally. The posterior wall is the transversalis fasciae, reinforced medially by the conjoint tendon. The roof is made of arched fibers of the internal oblique and transversus abdominis, while the floor is the inguinal ligament or rolled under edge of the external oblique aponeurosis with the lacunar ligament medially.
And why are those the locations, the borders? Tell me about the conjoint tendon too.
The borders of the inguinal canal are shaped by the layered arrangement of abdominal muscles and their aponeuroses, designed to create a stable passage for the spermatic cord or round ligament while maintaining abdominal wall strength. The external oblique aponeurosis forms the anterior wall and inguinal ligament floor for robust support. The transversalis fasciae forms the posterior wall as a deep barrier, and the arched internal oblique and transversus abdominis form the roof to allow dynamic movement like during straining. The conjoint tendon, formed by the fused aponeuroses of the internal oblique and transversus abdominis, reinforces the posterior wall medially near the superficial ring, acting like a shutter to prevent hernias by tightening when these muscles contract.
So the common aponeurosis of the internal oblique and the transversus abdominis is called conjoint tendon.
The conjoint tendon, formed by the common aponeurosis of the internal oblique and transversus abdominis, is located in the lower medial quadrant of the anterior abdominal wall, just above the pubic bone near the superficial inguinal ring. It strengthens the posterior wall of the inguinal canal in this region, helping to prevent inguinal hernias.
Okay, let's talk about the descent of the gonads a bit more and the development of the inguinal canal then.
The descent of the gonads begins around the 6th week of fetal development, when the testes in males or ovaries in females form in the abdominal cavity near the kidneys. In males, by the 7th month, the testes are guided by the gubernaculum, a fibrous cord, through the inguinal canal, which develops as a peritoneal outpouching called the processus vaginalis, reaching the scrotum before birth, while the processus vaginalis typically closes, leaving the canal as a passage for the spermatic cord. In females, the ovaries descend slightly, but remain in the pelvis, and the round ligament passes through the canal instead. The inguinal canal forms as abdominal muscle layers split around the gubernaculum's path, creating the deep ring and the transversalis fasciae, and the superficial ring and the external oblique aponeuroses, shaped by the layered aponeuroses to balance structural support with passage for reproductive structures.
Can we talk a bit about the layers of the testes and the spermatic cord?
The testes are covered by several layers, starting with the tunica vaginalis, a thin serous sac from the processus vaginalis, surrounding the testes except at its posterior attachment, followed by the tunica albuginea, a dense fibrous capsule directly encasing the testicular tissue. The spermatic cord, which suspends the testes in the scrotum, contains the testicular artery, pampiniform venous plexus, vas deferens, nerves, and lymphatics, all wrapped by 3 layers: the external spermatic fasciae from the external oblique, the cremasteric muscle and fasciae from the internal oblique, and the internal spermatic fasciae from the transversalis fasciae, derived from the abdominal wall layers as the cord passes through the inguinal canal.
Explain the cremaster muscle and the cremasteric fascia a bit more. The external spermatic fascia and all of this shit.
The cremaster muscle is a thin layer of skeletal muscle originating from the internal oblique muscle that surrounds the spermatic cord and testes, functioning to elevate the testes in response to cold or stimulation, like during the cremasteric reflex. The cremasteric fasciae is the connective tissue accompanying the cremasteric muscle, providing structural support, while the external spermatic fasciae, derived from the external oblique aponeuroses, is the outermost layer of the spermatic cord, encasing the cord and testes as a continuation of the abdominal wall's fascial layers.
Tell me a bit more about the layers. So we have dartos fascia and muscle after the skin. Then we've got external spermatic fascia, cremaster muscle and fascia, Internal spermatic fascia, parietal layer of tunica vaginalis, and then testis covered by visceral layer of tunica vaginalis. I just don't understand the order, you know?
All right, let's break down the layers from the skin to the testes in order, as if we're peeling back each one. Starting with the skin of the scrotum, the first layer beneath is the dartos fasciae and muscle, a thin layer of smooth muscle and connective tissue that wrinkles the scrotal skin and helps regulate testicular temperature. Next comes the external spermatic fasciae, a tough, fibrous layer derived from the external oblique aponeuroses, wrapping the spermatic cord and testes like an outer sleeve. Then, we hit the cremasteric muscle, a thin sheet of skeletal muscle from the internal oblique, bundled with its cremasteric fasciae, a loose connective tissue that supports it, allowing the testes to be pulled up reflexively. After that, you've got the internal spermatic fasciae, a delicate layer from the transversalis fasciae, directly encasing the spermatic cord's contents and testes. Moving inward, the parietal layer of the tunica vaginalis, a serous membrane from the fetal procesus vaginalis, lines the inner scrotal sac, while the visceral layer of the tunica vaginalis tightly covers the testes itself, except at its posterior edge. Finally, beneath the visceral tunica vaginalis, the testes is encased by the tunica albuginea, a dense, fibrous capsule protecting the testicular tissue.
I don't understand the order. You could have kind of persuaded me you mix the order, I would believe. Could you explain me the order in a couple of sentences?
From the scrotum's skin inward, the layers are skin, dartos fasciae and muscle, external spermatic fasciae, cremasteric muscle with cremasteric fasciae, internal spermatic fasciae, parietal tunica vaginalis, visceral tunica vaginalis covering the testes, and finally, the tunica albuginea encasing the testicular tissue. Each layer originates from abdominal structures, sequentially wrapping the spermatic cord and testes as they descend through the inguinal canal, providing protection and mobility.
Okay, now let's talk about the contents of the inguinal canal. Tell me about the spermatic cord, the ilioinguinal nerve, the ductus deferens, the arteries, the veins, the nerves.
The inguinal canal contains the spermatic cord in males, or round ligament in females, and the ilioinguinal nerve. The spermatic cord includes the ductus deferens, which transports sperm from the testes to the urethra, the testicular artery, supplying blood to the testes, the pampaniform venous plexus, draining blood from the testes, and autonomic nerves for testicular function, all wrapped in the external spermatic fasciae, cremasteric muscle and fasciae, and internal spermatic fasciae. The ilioinguinal nerve, from L1, runs through the canal, providing sensory innervation to the scrotum or labia and motor innervation to lower abdominal muscles, exiting via the superficial inguinal ring.
Okay. Now, lastly, I want to ask about inguinal hernias. I want you to explain to me direct and indirect, and medial versus lateral to inferior epigastric artery.
An indirect inguinal hernia occurs when abdominal contents, like bowel or fat, protrude through the deep inguinal ring, traveling the entire length of the inguinal canal and exiting via the superficial ring, often due to a patent procesus vaginalis failing to close after testicular descent. A direct inguinal hernia happens when contents push through a weak spot in the posterior wall of the canal, typically the Hasselbalch triangle, medial to the inferior epigastric artery, often caused by weakened abdominal muscles or conjoined tendon, and it doesn't traverse the deep ring. The inferior epigastric artery serves as the key landmark. Indirect hernias originate lateral to it, entering via the deep ring, while direct hernias bulge medial to it through the weakened posterior wall.
Yeah, could we explain this a bit more, why this medial versus lateral difference and how come inferior epigastric artery is so important in this situation?
The inferior epigastric artery is a critical landmark because it runs along the medial edge of the deep inguinal ring, dividing the abdominal wall into lateral and medial regions, which helps distinguish the origin of inguinal hernias. Indirect hernias start lateral to the artery, passing through the deep ring where the spermatic cord enters, following the canal's natural path due to a congenital weakness like an open procesus vaginalis. Direct hernias occur medial to the artery, pushing through the Hesselbach triangle, a weaker area of the posterior wall, bounded by the artery, inguinal ligament, and rectus abdominis undus hodum, due to acquired muscle or fascial weakness,
Okay.
like from...
Thank you for watching, guys.